And I'm a biologist, so you will not see cases, patients with my presentation, but I will try to give you an overview of biologics and PRP. I work in a regenerative medicine lab at the Galeazzi Hospital here in Milano, so I'm also really happy that you enjoyed the city, my city, and the Lake of Como in your trip. So, no disclosure, so orthobiologics, so biologics for orthopedics. This is for biological augmentation, but also it is just an overview of what orthobiologics may be, what they are. I'm sure all of you know what is orthobiologics, and they can be defined in very different ways. So they can be used to delay the need of surgery, to help healing, but also, as you see at the bottom, they can also be used for orthopedic surgery, like IV. Ligament repair reconstruction, and I will give you an overview of what orthobiologics may be and what you can expect from them. There is a very wide and complex category. There are different types of orthobiologics. Actually, we can divide them in two big groups. We have the cell-based products and the blood-derived products, and we will go a little bit through these two types of orthobiologics. So cell-derived products, so everything that is working with the presence of cells. What we can have with orthobiologics relying on the presence of cells. We can have tissue-specific cells, like mature cells or progenitor cells, if we think about adipose tissue with adipocytes. But of course, we can also have the mesenchymal stromal cells. So adipose tissue, bone marrow, the fetal agnesis, the cord blood. So there are very different type of products that are enriched with mesenchymal stromal cells. And how we can work with these products? They can be in vitro expanded, so ATMPs. Let's say everything that is prepared in a GMP facility. In Europe, in US, is very complex. The agencies are very strict. The advantage is that we have homogeneous cell population with, for example, mesenchymal stromal cells, very homogeneous, but the cost and the regulatory is very tough. Or they can be prepared at the point of care. So I mean to have tissues like bone marrow aspirate concentrate, we'll see, or adipose tissue that is prepared directly with the patient. It's much more heterogeneous, but it's more affordable, it's much cheaper, and with ethical concerns, there are very regulatory concerns, very less strict. So I will focus on mesenchymal stromal cells and prepare at the point of care. The two most common and known products are adipose tissue and bone marrow. What you see at the bottom is the number of cells, and mesenchymal stromal cells. In the adipose tissue is much more rich in mesenchymal stromal cells than the bone marrow. If you think in bone marrow, we have just a very thin percentage of mesenchymal stromal cells in the whole mononucleated cell population. So the numbers are quite different. And talking about the adipose tissue, also the way we prepare the adipose tissue to be administered to patients can really make different products. We can have the so-called stromal bulk fraction. So you can see on the left that is somehow enriched in mesenchymal stromal cell, adipocytes, but also leukocytes and erythrocytes, so it's more, let's say, more bloody. Or the microfat, nanofat you can see on the right, that is more clean from blood and blood cells, and is more enriched in adipocytes and in, again, MSC, adipocytes, pericytes, and progenitor cells. So in the first case, we really digest the tissue, so to have this stromal bulk fraction. In the second case, we disrupt the tissue, so depending on what we get at the end, so is it microfragmented, nanofragmented with microfat or nanofat. But also the bone marrow aspirate can be prepared and can be processed differently. There are many kits, many procedures. And this may affect the bone marrow aspirate, BMAC aspirate concentrate composition. The idea is to have, as much as possible, a pure bone marrow, possibly enriched maybe in stromal component, mesenchymal stromal components, and that is devoid of blood. Of course, if you ever drilled to collect the bone marrow aspirate, with the stroker, and then there are different systems, and what happens very easily is that after drilling, the blood can really feel the site of harvesting. So if you're not very quick, or if you don't use the drill in the right way, you can have a bone marrow aspirate, of course, that is really, really contaminated with blood. So what you have is somehow more than bone marrow aspirate concentrate, you have a blood preparation. So really, to have multiple collection sites, or to harvest small volumes, or maybe a particular trocar that you can move a little bit with the technique, can be really important to have an increase in mesenchymal stem cell content. And mesenchymal stem cells, what they do? The mode of action, so everybody knows about mesenchymal stem cells. At the beginning, let's say in the 90s, in 2000s, it was everything on the right. So the idea was you cut your finger, you put cells on top of your finger, and then your finger grows again. So because they differentiate, they do everything. So this was a great idea, but actually this is not really the case. What it looks like they do now, they can really differentiate, of course in the human body, but very slowly, in vitro, if you push them. But what they do is to interact with the environment and to release factors. So when you work with these products, you don't have to expect that these products can do something, can differentiate in what is missing, but can really educate the environment where you inject the cells. So they can be anti-inflammatory, pro-regenerative, so they can really re-equilibrate the environment, the homeostasis of the tissues and the environment. So this is the reason why Arnold Kaplan, that is kind of father of mesenchymal stromal cells, he proposed, you see in the bottom, to change the name from mesenchymal stem stromal cells to medicinal signaling cells. So cells are able to release messages and factors. This is, for example, something connected with tendons, just to give you an idea what they do. They can really stimulate, you see, the engraftment of the tendon, the extracellular matrix synthesis, the immunomodulation, the angiogenic, pro-angiogenic effect. But of course, what is very important is they can really modulate the pro-inflammatory environment you can find. They can move macrophages, for example, monocytes from M1, pro-inflammatory, to M2, anti-inflammatory. So they can really re-equilibrate the environment. Blood-derived products is something completely different. Of course, everything that is coming from blood is much more, much more known and used in clinical practice. This is the classical PRP, so blood-derived product is mainly platelet-rich plasma. So then we will see there are other type of blood-derived products. Platelet-rich plasma is the most common. The two most known products are leukocyte poor or leukocyte rich, and this depends on how you prepare the plasma. Of course, this depends if you want to have leukocytes or not. Just an example, in orthopedic regenerative medicine, there are different indications. For example, the leukocyte poor usually is more indicated for osteoarthritis, for muscle injury, for tendon repair, whereas the leukocyte rich with leukocyte is more indicated for tendinopathy. But there is still a big controversy about the use of PRP. Of course, we know that PRP works because we have platelets. So platelets have to be activated, so they have to degranulate to release factors, of course. In some system you have is that you can activate platelets before injection. You can activate, for example, with thrombin or calcium chloride, and then you release all the progress. So you can expect to have platelets activated, for example, with interaction with the collagens when you inject them, or you can pre-activate them before injection. And to have an already activate product. Then we have also other type of PRP, again in the platelet-rich plasma family, for example, the plasma-rich growth factor, PRGF. This is very important and very useful, I think, for your application, because again, you activate platelets, but you wait until a gel, a fibrin gel, you see at the bottom, a fibrin gel is formed, and it is very useful because it's a membrane. So you can shape, you can position. So let's say you can cover maybe if you're doing some work on your patient, you can cover the area where you did your intervention. So it's of course it's quite useful. And again, we have different type of membranes. We can have the plasma rich in fibrin, again leukocyte poor or leukocyte rich, could be poor content of leukocytes or high content of leukocytes. And so there are very different possibilities. So it looks like a little mess, so because there are not really, let's say, if you go in the literature, you see different preparation, different application of these products. Because also very often there is not a consensus about how to produce them and how to, well, the technique is clear, but the patient very often is not very well characterized, let's say. Because there is what we had in our lab. This is crazy. This is plasma. You can see fasting patients or patients, you know, after lunch, and you see the plasma how gets different. Sometimes it's, I say, kind of mayonnaise, and this one cannot be activated. You can put a lot of calcium chloride, nothing happens to the platelets. So this can make a difference. Now the protocol we have in our institute to have at least 4-hour fasting before application. So not only the type of PRP is important, but also your patient is important. For example, chondropathy, cartilage cells, they like hyperglycemia. But if you work with tendons, tendinopathy, for example, tendon cells don't like hyperglycemia. So the diet is important. They don't like cholesterol, they don't like statins. So what your patients eat can really affect what you have in your hands. It's something that now is getting popular, nutrition and regenerative medicine, but it's at the beginning I said, okay, come on, just don't worry. But now it looks like it's very important. Mode of action, I said, so activation of platelets, release of factors, chemokines, cytokines, growth factors, and so on. And this is what I said. The secretory profile of the platelets, not only the PRP itself, the plasma itself, but also their secretory profile, it changes depending on your plasma and on your patient. For example, in this publication, they showed that the release, not only the content of the plasma, but the release of platelets is different depending on fasting or not. You see, they recommend, these authors, they recommend to have fasting to reduce the release of pro-inflammatory factors. And this can also make a difference. So, okay, this is just a slide to see what PRP can do to tendons. They can, all these steps can be influenced by PRP. So when you use these products, maybe with your surgery, they can really work at different levels. And so the clinical application, just to conclude, there is just an overview. Of course, there is evolving, but actually the PRP with Orthobiologics, it looks like it's good for everything, but it depends really the type of PRP, the type of patient, but this can be a good starting point. The bone marrow aspirate concentrate is more for tendon ruptures and other reconstruction. And adipose tissue now is used for tendinopathies or tendon ruptures. We do sometimes with tendinopathies injection of orthobiologics in the tendon. It looks like it may work. And just for internal brace, just an example. I said that in the next session will be either talking about FAT or PRP. So it's just to see that there are more, literature for in vitro, preclinical or clinical, bone marrow aspirate, PRP. PRP is the most studied, and it looks like it really works. And so there are some authors that recommend to use orthobiologics in combination with surgery to improve the last one, for example, is a leukocyte-rich PRP blood clot. It's very easy. You can have a fibrin gel, you can cut, you can shape, and you can use with your surgeon. And these are our new hospital and the lab. And yeah, thank you. I'm sorry to change the time and the schedule. Thank you very much.